Greetings, everyone. My name is Dr. Jessica Pelletier. I'm an emergency medicine physician in the U.S. I'm the medical director for Techies Without Borders, and I would like to thank you for coming to our Continuing Medical Education Solutions Journal Club for November 2025. Our theme today is opioid analgesics, when to use and how to choose. I'm going to share the slides, and I would like to wholeheartedly welcome Dr. Chikezie Okwesileze. I do apologize if I didn't pronounce it perfectly.
That's all right.
Was that okay?
Yes, okay.
Excellent. Chikezie is a clinical pharmacist and kindly agreed to present for us today, and we are so thankful for him. And I will let him go ahead and get started. As always, this is designed to be a participating event. We want you to be engaged and involved and ask questions. Dr. Nicholas Maxwell, who is our medical education coordinator for Techies Without Borders, is an emergency physician, and he will be answering questions in the chat. So I'm going to mute myself, and I will let Chikezie take it away.
Yeah, thank you very much, Dr. Jess. Like earlier said, my name is Chikezie Okwesileze. I'm a clinical pharmacist. I work with the University of Calabar Teaching Hospital, Calabar in Nigeria. It's a teaching hospital affiliated to the University of Calabar. All right. As the topic has been introduced, we're looking at opioid analgesics. What to
Jess,
choose and how.
do you want to share the slides, Jess?
Yes, the slides are not shared yet.
There we go.
Okay.
Is that working now?
Yep.
Okay, perfect. Thank you.
Okay, it's on right now. Plan to achieve today. At the end of this session, we should be able to different types of opioid analgesics, the principles of opioid selections, self-prescribing practices and monitoring, and then risk mitigation strategies. Right. Our agenda today: introduction, cases, background, literature review, guideline review, and then we'll wrap up. All right. That's all. All right, introduction. Opioid analgesics remain essential tools in modern pain management, yet their use require careful consideration and clinical judgment. In this presentation, we will explore when opioids are appropriate, how to balance their benefits with potential risk, and key factors that guide the selection of specific opioids for patients. By understanding both their therapeutic role, their limitations, then we can make safer, more effective decisions in the management of acute and chronic pains. All right.
We'll go through a couple of clinical cases to get the ball rolling and get people started with engaging. Our first case is a 20-year-old male coming to the emergency department for accident and emergency after a boda collision, which is a motorcycle collision. He was the boda driver and was crushed by an oncoming vehicle and has extensive injuries to the right side of his torso, as well as his right upper and lower limbs, including open fractures. How should you manage this patient's pain in the acute setting? We would love to hear from people in the chat. Feel free to chime in out loud or in the chat as to how you would manage this patient's pain from a crush injury.
Very dodgy.
So I know in my setting, working in a trauma center in the United States, I would generally treat this patient with opioids, typically something like fentanyl, which is short acting and hemodynamically neutral, meaning it does not typically cause hypotension. The other option in my setting would be ketamine. I would love to hear from people in the chat what they might use for a patient with a crush injury while we move on to case 2. So case 2 is a 73-year-old gentleman who's presenting with a left distal radius fracture. He takes daily oral anticoagulation, has a history of peptic ulcer disease, and is allergic to paracetamol. What pain medication could you discharge him with? Oh, and we just heard from Sidwell in the chat. Hi, Sidwell, and thank you. He said for the patient with the crush injury, I believe, combined analgesia with IV paracetamol and fentanyl. I think that's a wonderful choice. You're hitting the pain at 2 different receptors, so you're hitting it in 2 different directions. How about this patient with a Colles fracture or a distal radius fracture? What would be some potential pain treatment options for this patient? Janet, I think you said an opioid. Is that what you said? Yeah, so this patient is allergic to paracetamol and he has multiple contraindications to using NSAIDs, including anticoagulation and a history of peptic ulcer disease. So an oral opioid, cautiously, might be a good choice for him. Keep in mind with his age, he's at higher risk for dizziness, falls, delirium compared to younger patients. So I would be very cautious and not give large doses, but you could potentially send him with a short course of oral opioids to go home. Here's case 3. You have a 35-year-old female with metastatic breast cancer presenting with severe pain after running out of her chronic daily opioids 2 days ago. She's sweating, endorsing vomiting and diarrhea, has obvious goosebumps on your exam, is diaphoretic, and has dilated pupils. What are the most appropriate next steps in management for this patient?
Is goosebumps a term that is readily used in Africa? I recognize that might be a bit of a
Great question.
idiom.
So that's piloerection would be another term for that.
Oh, cool. Wasn't sure if that was I wasn't sure if there was geese in Africa.
I don't actually know, but maybe it sounds like, according to Nasra, that we all use that term. I don't know who came up with that one, but I suppose that piloerection looks a little bit like
cool.
goose flesh. Good to know. Thank you, Nasra. So first of all, if someone wants to chime in the chat, Nasra or someone else, what sort of presentation is this? This woman ran out of her opioids and is now endorsing multiple symptoms. What is going on with her? Awesome. Yes. She's in opioid withdrawal, right? So what would be some appropriate treatment options to help her with her pain?
I couldn't quite make that out, Jane. Are you able to put that in the chat?
So I would treat this patient. Oh, excellent. Thank you, Sidwell. You said a long-acting opioid like methadone. I think that would be a fantastic option if you can't give her a refill of her home opioid prescription, because I'm guessing it's a large dose. And yeah, restart opioids would be the first line option. But if in your setting you can't prescribe the large doses that she's been on at home, then giving something like methadone to temporize her symptoms till she can get in with her provider could work. Another option would be something like buprenorphine naloxone or buprenorphine, and we'll talk about that later. I'm going to switch it back over to Chikezie and let him talk about the background and literature review on opioids, and then we'll circle back on some of these concepts throughout the presentation.
So, sorry, please, Dr. Jess, please, I appeal it can continue. My network is so erratic here.
I can hear you well, Chikezie.
Yes, but my network is so poor. I appeal Dr. Jess to carry on, please.
We can hear you okay.
Yes, my network is poor. Network is very poor here.
Do you want to give it a try, just because right now we can actually hear you really well, and then if we can't, we can switch over?
Dr. Jess, please help and continue, please. Sorry, Dr. Nick, can you hear me?
Yeah, no, we can hear you fine. Your clarity is actually probably one of the best out of all of us right now. It is let's have you try, especially since you made these slides. We can have you try, and then Jess and I can help if the connection starts fading out.
Sorry.
All right, I will go ahead and present then. So opioids are potent analgesics that act on the mu, kappa, and delta receptors that are used for acute and chronic pain. They have a high potential for misuse and dependence. And I did a bunch of reading. Chikezie sent a wonderful article to me. It sounds like opioid dependence in terms of opioid use disorder is not as common in Africa as in the setting where we work. Here in the US, we have a major problem with that. And Africa actually prescribes the least opioids out of any continent. So these drugs do require careful evidence-based prescribing in order to prevent addiction and issues like withdrawal, such as what we discussed for that third patient. So in terms of different pain types and classification, acute pain can be due to things like trauma, surgery, or invasive procedures, like that Bota patient that we talked about earlier. And patients with traumatic injuries like that, absolutely, you should be considering opioids if they're available in your setting, especially if there's contraindications to NSAIDs for the patient. Chronic cancer pain and other chronic types of pain, such as neuropathic and musculoskeletal pain, can be controversial in terms of treating with opioids, but often there's no other option to relieve people of severe chronic pain. And so that is typically what we end up using, especially for cancer pain. And then opioid effectiveness varies by pain type. So when are opioids actually indicated? I would say in moderate to severe acute pain not relieved by non-opioids, in cancer-related pain, in the setting of palliative care and end-of-life care, and then in post-operative settings for patients who have functional impairment. So situations where opioids are not first line, chronic non-cancer pain, other than in the setting of sickle cell. And I know we've had a prior journal club session, sickle cell disease, and it sounds like many of you are able to treat sickle cell with non-opioids as well to treat their pain. But here in the US, I know we frequently use opioids for sickle cell disease. Headaches, multiple guidelines from multiple countries state that opioids should not be used for headaches. I know we see frequently here that people want to give opioids when other medications fail, but those drugs are simply not effective for treating headaches. Fibromyalgia, neuropathic pain, given that opioids don't target the correct receptors for that, and then mental health disorders without a pain diagnosis. So the stepwise approach to pain management follows the WHO analgesic ladder. We should be using non-opioids first, followed by weak or short-acting opioids, and strong or long-acting opioids should be used last. But we should always be using multimodal approaches to treating pain. Like Sidwell mentioned earlier, combining an opioid with paracetamol or with something else can really help cut down the amount of opioids that you need to use. I know in my setting, we use a combination of ketamine, nerve blocks, and especially for patients who have musculoskeletal issues that are causing their pain, fixing the underlying traumatic cause of pain is going to be the number one thing that helps. So for a patient with a distal radius fracture, like we mentioned earlier, doing a hematoma block goes directly to the source of the pain, and then reducing the fracture will fix the pain as well. So in terms of types of opioids, natural opioids include morphine and codeine. And semi-synthetic opioids include hydrocodone, oxycodone, and hydromorphone. It should be noted that if a patient has an allergy to morphine or codeine, they are often able to take the semi-synthetic or the synthetic agents. And so these don't always cross-react. If a patient does have an allergy listed to codeine, I'm a little more hesitant to use something like morphine. But if a patient has an allergy to morphine, I often can get away with giving fentanyl, hydromorphone, hydrocodone, etc. Note here that the synthetic agents like fentanyl, methadone, tramadol, and tapentadol, that's something we don't have in our setting. Those drugs often do not show up on urine drug screens. So if patients are on chronic opioid therapy and they have to have drug screens for monitoring of their opioid use, then keep in mind that you may not see those drugs on their urine drug screen. In terms of short-acting versus long-acting, short-acting drugs are often referred to as immediate release, and they're rapid onset and short duration. These are used for acute pain or for breakthrough pain. So in the emergency department, we'll often use IV fentanyl or morphine to treat acute pain. And in terms of immediate release oral opioids, in our setting, we'll often use oxycodone or oral morphine, sometimes hydrocodone. I would love to hear in the chat what oral short-acting opioids, so what immediate release formulas are most common for you guys, because there are a lot of different agents, I'm sure, from what we use here, depending on availability and cost. I'm just going back through the chat here. It looks like Sidwell says you guys have fentanyl available in Kampala, at least in the OR, but running out of stock can be a problem. Interesting. So factors to consider when choosing an opioid: the pain severity and type. So how long is this pain going to go on for? If it's going to convert from acute pain into chronic pain, then getting someone started on opioids is probably not the best choice. If someone's on opioids for 3 days or more, it substantially increases their risk of progressing to opioid use disorder. So always consider that. And then thinking about the patient age and comorbidities, whether they have renal or hepatic impairment, because that's going to lead to decreased clearance of these medications. So that can actually increase the risk for hypoxia, delirium, and other side effects. And the drugs are going to last longer if they're not being cleared by the kidneys or the liver. So I'm often considering, when giving something like morphine or fentanyl to a patient with end-stage renal disease or cirrhosis, I'll start with half the dose that I typically would and see how they respond. And if they're still in pain, then I'll give them the rest of the dose that I would give someone of an equivalent body size. Think about whether they've had previous opioid exposure. So if someone's on chronic daily opioids, it's worth calculating their morphine milli equivalents using a tool like MD Calc, and then dividing that over the hours of the day so that you know how many milligrams of morphine they're getting per hour. And you can use online tools to help you figure out what dose would be appropriate of whatever opioid you are giving them. So for example, if you would like to give them a dose of tramadol, which is a drug I don't like, but I know some of you have that available to you. If you're giving them a dose of tramadol, you can look at how many morphine milli equivalents it would be so that you're treating their acute pain with a larger dose than what they get for their chronic pain. Pay attention to any drug interaction. So if you're also giving something like a benzodiazepine around the same time, that will really increase the risk of respiratory suppression and hypoxia. So being cautious about what other drugs they're taking simultaneously. So in terms of initial opioid selection, start with a short-acting opioid and use the lowest effective dose. and then reassess their pain, function, and side effects frequently. And then considering a trial, consider the trial duration and the endpoint. Like I said before, 3 days or more of an opioid prescription can put a patient at risk of dependence. And also considering if you're sending someone home with opioid therapy, they may need naloxone to go. I will send almost all my patients who get an opioid prescription with naloxone, the reversal agent, to make sure that they have a safe option if they accidentally take too much. I would love to hear in the chat who has naloxone available in their setting as a prescription. I know that's not always available. So let's talk about equianalgesic dosing. So this is used for switching opioids. This is actually what I just talked about a little while ago, is that you can calculate the morphine milliequivalents that someone is taking, and then look at how many morphine milliequivalents that would be of another opioid agent. Be careful to reduce the dose when converting by 25 to 50% to ensure that you don't accidentally overdose the patient. So it's better to give them a little bit less than the equivalent in morphine milliequivalents. And then if it's not enough, you can always add more, but you certainly can't take back opioids. You can reverse them, but if you give someone naloxone, then they're going to be in substantial pain until the naloxone wears off. In terms of renal impairment, fentanyl or methadone are a little bit safer options. And then for hepatic impairment, we should avoid large doses of oxycodone and hydrocodone. Patients who are pregnant, opioids should be avoided unless medically essential. So I would try paracetamol first. Remember that NSAIDs are also contraindicated in pregnancy. So if someone is truly suffering, I would not withhold giving them an opioid, but be careful that if the baby is close to term and it's something long acting, then that can lead to respiratory suppression in the newborn baby as well. So in terms of opioid titration principles, adjust the dose based on pain control and side effects. Should increase by small increments. And then for long-acting opioids, titrate no more than every 3 to 7 days, because it does take several days for you to see whether a dose is really working for someone or not. So in terms of side effects, to be aware of, constipation is one of the most common. And if I'm sending someone home with opioids, I'll often tell them to take polyethylene glycol, which we call Miralax in our setting, daily while they take that. And I may even send them with a concomitant prescription. I'm curious if other people are sending their patients they're giving an opioid prescription with prophylactic stool regimens. Nausea is more common with the natural opioids like morphine and codeine than it is with the synthetic and semi-synthetic agents, but it can happen with any of them. So be ready to treat that. And then sedation, if someone becomes over-sedated with the dose that you give them, simply give a smaller dose the next time if you're re-administering it. For itching, which is more common with morphine than with other agents and is caused by histamine release, you can treat that with antihistamines, but it is a temporary side effect and will typically wear off. And then it can't be emphasized enough that you should be watching for respiratory depression and ready to reverse with naloxone if needed. Janet said, everyone using morphine should have naloxone in case of respiratory depression. I absolutely agree. I send all my opioid prescription patients with a naloxone prescription too. Okay, so opioid stewardship, emphasizing functional goals. And so realizing it's important to set sort of boundaries with patients and explain we're not going to be able to take away all of your pain forever. We're giving you this prescription to make your pain tolerable so that you can get back to your daily function. I know that patients will often call, like if you're in an outpatient setting working in something like orthopedics, when the medications wear off or they run out, they will often call asking for refills. And you have to be realistic that they're going to be in pain. But if they're in an excessive amount of pain for the point of healing that they're at, then they need to come back for a reevaluation because other things could be wrong, like compartment syndrome or infection. So they need to have appropriate return precautions. So in other words, when they do go home, explain you're going to be in pain. It's going to get better every day. If it starts getting worse more than a few days out from now, that's unexpected and we want you to come back. And just be prepared that when the opioids wear off, you will have more pain. So you have to be prepared for it mentally. In terms of opioid therapy and acute pain, remember, again, multimodal therapy. We're going to repeat this several times, but combining with NSAIDs, paracetamol, and regional blocks can be super helpful. Opioids for chronic pain, as we discussed, for sickle cell or for cancer pain can be very effective, but consider adjuvants like steroids or anticonvulsants or things like selective norepinephrine reuptake inhibitors if the patient is potentially reaching unsafe doses of opioids. And try to taper people off these medications, especially if they aren't being particularly helpful for treating their pain. So for breakthrough pain management, we should be using 10 to 15% of the total daily opioid dose and using fast-acting formulations when we're treating an acute breakthrough. So I often will see my residents ordering a dose of morphine, like 4 milligrams for a patient with chronic cancer pain. That's simply not going to do anything for them. So you need to calculate the morphine milliequivalents that this patient is taking and think about how many milligrams are they actually getting every few hours. And that will give you a sense of how much more you need to give them to actually treat their pain. A dose that might be adequate for you and I will not be adequate for someone who has chronic dependence. Opioid rotation is a concept that I don't deal with as much in the emergency department. It's more of an outpatient setting thing. But if a patient has chronic pain being managed with opioids, you can certainly try switching them to another opioid when one stops being as effective or when side effects are intolerable. So if someone is having so much constipation and nausea with a particular opioid that they can't tolerate it anymore, you can certainly try a different one. And then realize again that you'll have to convert the dosing to make sure you get it right. For tapering and discontinuation, this is going to have to be gradual. You certainly can't cut someone off in the short term from opioids without realizing that you will give them opioid withdrawal. So they will present with the symptoms we discussed earlier. They'll present with symptoms like sweating, piloerection, nausea. They may come in with vomiting, runny nose, enlarged pupils. Patients will need a slow reduction in order to avoid these symptoms. Oh, Janet just mentioned in the chat that she is a palliative care physician and using oral morphine every day with her patients, and virtually all are given bisacodyl. That's great. Yeah, in other things that I've tried for patients with chronic opioid dependence with terrible constipation who come back to the ER, let's say they're already taking things like bisacodyl and polyethylene glycol, I'll add glycerin suppositories. And then we're blessed here to have access to a drug called methyl naltrexone. It's a medication that actually specifically reverses opioids in the gut. I am curious if anyone else has access to methyl naltrexone because it's a lovely drug, but I am aware it's expensive, so it's not something I order very frequently. Okay, in terms of recognizing opioid misuse, being careful to not prescribe opioids to folks who have a history of a substance dependence, whether that's alcohol or some other drug or opioid dependence in the past, probably not the right person to give an opioid to. So whenever I discharge someone with an opioid for acute pain, I ask them, have you had issues with opioids in the past? And if they say yes, then I look for another agent we can give them. And then if they're on high doses or long-term therapy, if you're managing this patient in the emergency setting, you're probably not going to be able to treat their pain as well as you would like, but need to make sure that you set them up with appropriate outpatient pain management or palliative care, depending on what's available in your settings. Sidwell says he's read that ketamine can help with opioid tolerance. That's a really excellent question. So I guess, are you referring to helping for patients who have high dependent or like high tolerance to opioids? Would ketamine be a good choice for their pain? If so, yes, absolutely. And I use that all the time. You can give pain doses like 0.2 to 0.3 milligrams per kilogram. Do realize that wears off in about 20 to 30 minutes. And so it's not going to be a long lasting agent, but it's really wonderful for the patient who is not responding well to opioids or who's chronically opioid dependent and or even has a history of opioid use disorder. And I'll often have those sorts of people come in and say, hey, I don't want any opioids, but I have a broken bone. What can you do for me while we're getting everything ready to fix my bone or something like that? So pain dose ketamine is a great choice there. Now, there are prescription monitoring programs where I work, and it sounds like probably where Chikezie works as well. So keep in mind that if you have a prescription monitoring program, you should be checking it before prescribing opioids to make sure that someone's not I guess we'll call it shopping around or seeking prescriptions for opioids from multiple different healthcare providers without the knowledge of the others, because that is certainly a red flag for opioid use disorder abuse and possibly for the patient diverting the medication and selling it for street value. Having treatment agreements, if you're prescribing opioids in the long term, if you're a primary care doctor, pain management doctor, or some other specialist who's going to be prescribing opioids to a patient for a longer period of time, it's probably good to have them sign a treatment agreement. And then regular urine drug screens and frequent follow-ups are very helpful to ensure that the patient is actually taking the medication the way they're supposed to. I know my husband works in primary care and he has several patients who are on long-term buprenorphine or methadone for management of their opioid use disorder. And if they come in and their drug screen is clean, meaning that those medications are not detected in their urine, then that raises concern that they may be diverting the medication, meaning selling it. And so it's important to monitor those things. And then we shouldn't really be prescribing benzodiazepines for folks in the long term at home. Most of us know that that is an addictive medication that is great in the short term for many things. It's great for aborting seizures. It's great for muscle relaxation and anxiety in the acute setting, but it's not a great medication to be on long term due to the addiction potential and also the danger of withdrawal. So benzodiazepine withdrawal can be fatal, just like alcohol withdrawal. So being cautious to avoid prescribing concurrent benzodiazepines, but also just prescribing benzos in general when they're not just for as needed use can be quite dangerous. Remember that combining the benzodiazepines with opioids can cause respiratory depression. So medication-assisted therapy is something I wanted to touch on here. We have mentioned buprenorphine and methadone multiple times here, but medication-assisted therapy, or MAT, refers to using these long-acting opioids that do not have as euphoric an effect as other opioids. Buprenorphine is a partial agonist of the mu-opioid receptor, and so it doesn't give people the high that many other opioids do, but it helps keep them from going into withdrawal. Methadone, I think, has a little bit more addiction potential than buprenorphine in my experience, and we aren't allowed to prescribe it in my accident and emergency unit, but I know there are some emergency departments that prescribe methadone. My personal favorite of these three options is buprenorphine naloxone. So this drug prevents abuse potential because if you try to crush it and inject it, you won't get a high, and that's why there's naloxone added to it. So it actually has a protective effect there. So that is typically the first line drug that we're giving for medication-assisted therapy in my setting, but I would love to hear from people if you're mostly using methadone or if you're using buprenorphine. One key thing to remember about methadone is that that is a QT prolonging drug. And so if the patient is also taking multiple psychiatric medications, let's say antipsychotics, they're taking selective serotonin or norepinephrine reuptake inhibitors, you do have to be cautious with methadone use. The other group of people that can get into trouble are folks who are highly likely to get hypokalemia, hypomagnesemia, or hypocalcemia, because those can prolong the QT as well. So, for example, patients who have chronic recurrent vomiting or people who have issues with starvation ketoacidosis, patients who are chronic alcoholics. We shouldn't really be giving opioids to those people anyway, but just remember that someone who's at high risk for electrolyte derangements in terms of low potassium or magnesium, things like that, is going to have a long QT, and the risk of putting them into a fatal dysrhythmia with methadone is higher. I did want to remind everyone, I sent out an EM Docs free open access medical education article. It is also on the CMES devices if you have one at your site. And this is a great article that has a table with the dosing for all of the medications that have been mentioned today. There are some opioids available in Africa that we don't have in the States and which may not be in that table. But I did want to highlight the dosing of buprenorphine and methadone for those who may be less familiar, because it's a little bit different than with some other opioids. And as you can see on the right, that the analgesia duration is really long. So buprenorphine lasts for 24 to 72 hours, which is amazing. And it's why it's usually our first line choice for medication assisted therapy. But definitely check out this table in the article because it has the dosing for many different opioids in it, both IV and oral. If you're going to give someone medication-assisted therapy, you need to determine if they're in withdrawal right now, because if you give someone buprenorphine naloxone, which, like I said, is a partial mu opioid agonist and also has naloxone in it, you may actually precipitate withdrawal if they're not already in withdrawal. And so it's really important to see, are you in withdrawal now? Because that is an indication to go ahead and give a dose of buprenorphine naloxone. This is not as much of an issue with methadone, but just keep in mind that someone should be in active withdrawal before you give buprenorphine naloxone or really any medication-assisted therapy in the acute setting. If they're not in withdrawal right now, then I show the patient what these types of symptoms are. Most of them know what opioid withdrawal feels like because they've experienced it. Like patient 3 that we had earlier with piloerection, with the dilated pupils, the nausea, the abdominal cramping, all of those things they've probably experienced before, and they'll know when to take the medication at home when they experience those symptoms. The COWS score is available on MD-Calc, and I use it with my residents all the time, and it shows you what level of withdrawal someone is in. And if they are in moderate withdrawal, then that's appropriate to give buprenorphine naloxone or for someone to self-administer that medication at home. This is another plug or reminder to prescribe naloxone with your opioids. I don't know if anyone commented in the chat if they have access to naloxone on a regular basis. At one of the sites where I work in Virginia, they have take-home naloxone that comes in a backpack for their homeless population. So they'll give them a backpack with like resources in terms of finding homeless shelters. It'll have clothes in it, it'll have snacks, and then it has naloxone in the bag too. We now have take-home naloxone at my primary site in Missouri, which is great. And I was recently in a city here in the US where there was a free naloxone dispenser on the side of the road, kind of like where you'd pick up a newspaper. It's a newspaper stand that you can just dispense free naloxone from, which is great. I just wanted to quickly go through the guidelines from Uganda and the Gambia, since you guys have national guidelines. So in terms of pain management in adults, the Ugandan guidelines recommend that for mild pain, you avoid opioids. So this is the same thing we do where Nick and I work, is we'll usually start with paracetamol and or ibuprofen. Another option for an NSAID here would be diclofenac. Keep in mind that ibuprofen is probably the safest of all the NSAIDs when it comes to the risk of GI bleeds and peptic ulcers, as well as renal impairment. So it's typically a good choice if you don't know enough about your patient to say for certain that they don't have those issues. That being said, please do not give NSAIDs to patients with known kidney disease or a known history of GI bleeding or anything like that. And it's important to emphasize with patients to take appropriate doses of paracetamol, since there is a risk of liver toxicity and death and overdose, which is pretty serious. And so they need to be very accurate about the doses that they take at home. For moderate pain, the Ugandan guidelines suggest using morphine, codeine, or tramadol. I don't typically use codeine or tramadol in my setting. There are people who have difficulty metabolizing codeine, and there are ultra rapid metabolizers, and so it can have erratic effects in the body, and not everyone will respond similarly to the same doses. It's especially dangerous for pregnant and breastfeeding women because the doses that are received by the fetus or the baby can be incredibly high relative to what the mom gets. So use caution with codeine. For tramadol, to keep in mind, it is a drug sort of like I would say the most similar thing I can think of in my mind would be diphenhydramine, in that it hits a lot of receptors and not just opioid receptors. And so tramadol can increase the risk for seizures. It can cause QT prolongation. So keep in mind that there are more side effects to be aware of if you're going to prescribe tramadol. Morphine, as we mentioned earlier, can Nick just said some toxicologists he knows call it tramadol. But if that's what's available in your setting, it can be a very effective pain medication. Just keep in mind that it does have some side effects like lowering the seizure threshold and QT prolongation. Morphine, the most common side effects that we see are itching or pruritus and nausea, but that does not always happen. Just be prepared to treat that. And then for severe pain, the Ugandan guidelines recommend higher doses of morphine. And then if there's breakthrough pain, giving equivalent additional doses and increasing that dose by 30 to 50% as required to control the patient's pain. They're not specifying whether they mean IV or oral. I would assume they mean IV here. If you're having severe pain, it's unlikely you're going to be able to tolerate oral pills. But there are plenty of people who can take oral morphine even when they're in a lot of pain. These are adjuvants suggested by the Ugandan guidelines to help with pain control, especially for people with chronic opioid use. You should consider using an adjuvant like an SNRI if that's available to you. Amitriptyline is suggested here. That is also a great drug for pain control, though it is quite dangerous in overdose. So you have to trust your patient that they will take it correctly. I would also be cautious with co-prescribing benzodiazepines. They list that as second line, and I would agree with that. It is very dangerous and can cause respiratory depression if you co-administer those agents. Dexamethasone can be great to give acutely, but I probably wouldn't give it for multiple days in a row for pain control, given the long list of potential side effects. So chronic steroid use can cause decreased bone density and osteoporosis. It can cause avascular necrosis. And certainly we're all aware of the acute effects, things like increasing blood sugar and causing delirium, as well as increased nightmares. It can cause psychosis and exacerbation of underlying neuropsychiatric disorders. We don't have high codeine at all of our hospitals. We do have it at the hospital where I work at now, and I find that it's really wonderful for things like bladder spasms. So I've used it for that, or for tenesmus, like for rectal spasms, but we don't use it super often where I work. So I'd love to hear if people are using that a lot where you work. And then again, they mentioned diazepam. Again, please be careful co-prescribing opioids and benzodiazepines. In terms of pain management for children, you'll notice it looks very similar. So for mild pain, paracetamol or ibuprofen are most appropriate. For moderate pain, again, we're looking at morphine, and thankfully the Ugandan guidelines have the weight-based dosing. I love that the guidelines in the right side of the table recommend using a stool softener. They mentioned bisacodyl, which is the same thing that I believe Janet mentioned earlier. That's a great choice to help prevent constipation. And then being very cautious about increasing the dose and titrating it. They do note on the right that codeine and tramadol are not used in children, and I'm very glad they have that note there. They can be dangerous in adults too, but particularly in children who have erratic metabolism of drugs compared to adults. The adjuvants they mentioned here for kids are a little bit different. So amitriptyline is seen again for neuropathic pain. They also mentioned carbamazepine, which has a lot of potential side effects. So that's why it's listed as a second line agent. Many of us know that as an anti-epileptic agent. I probably would not prescribe carbamazepine unless I had no other options for adjuvants to treat someone's pain. And then prednisolone, again, be cautious about giving steroids for pain in a long-term setting, especially for a developing child who, if they get avascular necrosis or decreased bone density, that's going to have more serious long-term effects than for an adult. The Gambian guidelines look quite similar. So for mild to moderate pain, they recommend using oral paracetamol or NSAIDs like ibuprofen and diclofenac. And then the choices for oral opioids are a little bit different in the Gambia than in Uganda. They use dihydrocodeine or tramadol. I'm not seeing an option for oral morphine here like we saw for Uganda. So if anyone from the Gambia is online today, I would love to hear whether you have access to any other oral opioids, what other things you might be using besides codeine and tramadol. For severe pain, they suggest the use of morphine, pethidine, or pentazocine. We don't have pentazocine here, and pethidine, which is also known as meperidine in the US, has gone out of favor because it has a lot of potential side effects and can have erratic results on patients. So I'm a little more cautious. I know that meperidine can be a great drug, but typically we would go with morphine where I work because it has more reliable effects and you know what you're getting, if that makes any sense. In terms of opioid overdose, the Gambian guidelines do highlight the importance of stopping opiates and giving naloxone up to 10 milligrams slowly. That's a massive dose. I would be very careful.
That's a lot of naloxone.
So for context, I usually give 0.4 milligrams of naloxone for someone who's opioid naive, and then I'll repeat up to 2 milligrams, typically at most. If they're a chronic opioid user, I'll start with very tiny doses. And Nick, you can put these doses in the chat. 0.4 milligrams for opioid naive, and then 0.04 milligrams for someone who's a chronic opioid user, because if you give them a large dose of naloxone, you're going to put them directly into withdrawal. So tiny, tiny doses, just enough to keep them breathing and get them out of severe respiratory depression, are usually effective. And the dose that comes in the intranasal form for naloxone in our setting is 0.4 milligrams. I'm curious if you have the same dosing where you work, but the risk with giving high doses of naloxone quickly is that it can precipitate non-cardiogenic pulmonary edema and lead to acute respiratory distress syndrome, or ARDS, which can be fatal, particularly if you don't have access to a ventilator. And so I would use great caution with giving large doses of naloxone. Titrate slow and just observe and see how someone does. It's better to give them a tiny dose and put them on supplemental oxygen until they are fully recovered. Nano said, we do have oral morphine, but tramadol is more readily available. Thank you for commenting on that. Glad to hear that you got a couple of options available. So at this point, I'll give a minute or two here. I would love to hear what institutions are doing. Janet says pethidine should never be used in cancer pain, horrible drug. I agree. It shouldn't be used for like anyone based on what I was reading. And it's why it went out of favor in the US. We don't use pethidine here at all anymore. And as I said before, that's also known as meperidine where I work, in case you have heard both terms. All right, well, you can feel free to chime in the chat what drugs your institution is using for the management of opioid use disorder or for the treatment of pain with opioids. I would love to keep hearing your thoughts and sharing what practices are happening at different places. So in terms of the summary, you should only use opioids when the benefits outweigh the risks. Remember that first-line agents are safer, like paracetamol and NSAIDs, and that there are other things you can do to treat people's pain. Start low, go slow, and reassess regularly to avoid overdose. And then choose your agent based on patient factors and pain type. So if it's neuropathic pain, you're probably not going to help them with an opioid. So thinking about using another agent may be a good idea. Practice safe prescribing and monitoring, watching carefully for red flags that someone might have an opioid use disorder and should probably not have a prescription for opioids. And then try to integrate non-opioid and non-pharmacologic strategies. I will put in a note here that I'm an osteopathic physician, so I do a lot of manual manipulation with my hands to treat pain. So if that's something in the scope of your practice, or even just giving someone a massage if they have a headache or neck pain or upper back pain, if you have a couple extra minutes to lay your hands on the patient, that can be really beneficial, both from a placebo standpoint, but also from a therapeutic engagement with the patient standpoint, can really help them feel better. These are the references, and I want to thank Chikezie so much for making these slides. I'm sorry that the reception was not adequate today for him to do the presentation, and I'm very appreciative of the hard work he put into this, such excellent key learning points for all of us. I'm going to share a link in the chat to our survey. I do apologize that we did not get time today to do pre and post questions. I know many of you have asked for that, and we will try to resume doing that next month in terms of baseline knowledge and then doing a post test. But please feel free to chime in the chat if you have any questions, thoughts, ideas that you want to share. I love what Janet just said. Please do not be pushed into giving morphine for musculoskeletal pain. Could not agree more. I have patients come in all the time for simple musculoskeletal pain who I'll give them Tylenol and ibuprofen. They say, or some other NSAID, they'll say, oh, my pain's not better. I want oxycodone or I want morphine. And I will say, well, you can have a trigger point injection or osteopathic manipulation or a lidocaine patch, but I will not be giving you an opioid. So offer them all the other things you have in your arsenal wherever you work, but they should not be getting opioids for acute musculoskeletal pain unless they're, they have a fracture or something severe. Sidwell, thanks for mentioning we do use fentanyl patches as an alternative in addition to the IV. Yeah, you just have to be super careful to avoid overdose, but that's great because then you have both a long and short acting option there. And then ketamine and paracetamol are your non-opioid options. That's really wonderful. Thank you guys so much for all the comments in the chat and for how engaged everyone was today. I really appreciate you chiming in and answering questions and sharing your thoughts. Like I said, thank you for your patience with the internet issues, and I'm sorry for the background noise today. I hope I was still audible. And many thanks and a huge shout out to Dr. Chikezie, who made these wonderful slides, and I am sorry about the reception. Thank you, everyone.
Thank you.
Thank you.
Well done, Jet. Well done, Nick.
Thank you, Emmanuel. Appreciate you as always. Thanks for being here.